Okay, everybody, welcome to Journal Club. I have to figure out what month this is, but I know it's 2018. Hopefully there's somewhere between 7,000 and 10,000 of you who will be watching this video. We are here again at the New Jersey EMS Fellowship doing Journal Club. I'm supposed to tell you to like us on Facebook so everybody knows we're live, but it's our usual Wednesday at 1 o'clock. If you're not going on our website recently, please do so, www.emsfellowship.com. And we are moving slowly into the social media age. We have our new and improved Twitter account, which is at MD1 Program, and an Instagram now, which is at MD1 Program, and a Facebook page, and anything else I'm forgetting? That might be it. If there's anything else, Twitter, I said. Okay. So if there's anything else to get, we'll figure it out. So we're going to go through the usual stuff. The guys have been all over the world as usual last week, and coming up we have another busy week. And please ask your questions or type them in as we progress through Journal Club. We'll go for about an hour and a half today. And today is our last day, hooray, of interview season. So our June, July, August, September, October, 4 straight months we've been going, and today is the last day. So we now will start rotating again between North and South Jersey, where we've been down in South Jersey for 4 straight months. We'll get started with interesting cases. So who has interesting cases?
So I had a pretty recent case. Recently had a case, a younger patient with a history of severe heart disease. Thanks. Severe heart disease, pretty much on the transplant list with a left ventricular assist device, and essentially came in because felt the defibrillator go off 4 times, was uncomfortable, comes in and is in a persistent VFib. Awake, talking like most LVAD patients are, just sitting there playing on his phone, saying that he just feels his defibrillator going off. And
right, so we people who run like LVAD programs or heart failure programs see people walk in VFib every now and then. It's not the weirdest thing in the world, but you know, a friend of mine who runs a big heart failure program says, think of the LVAD patient as the healthiest patient in the hospital, right? And that's totally true because you can't mess them up, right? What happens when an LVAD patient gets an infarct to the LV? Nothing, right? Sometimes they get some aortic insufficiency, that gets them in trouble. And sometimes they infarct their right ventricle, which isn't that common, but that can get them into trouble. But LVADs are extremely stable patients. They go into VF and they can be asymptomatic. You can't hurt that patient.
Yeah, okay. And that's essentially, this guy was, other than feeling the defibrillator going off, otherwise asymptomatic patient. Comes in VFib, immediately contact the heart failure team and the LVAD team, so come join us. But the guy's in VFib, treating him with magnesium didn't work, lidocaine didn't work, amiodarone didn't work. He's on amio drip, lidocaine drip. Decided to do procainamide, didn't work. So
all right,
finally,
so stop there.
Yeah.
So so the question, Alex, told me what happened, and this is like an old. So what would you do now? What would you do now? To the thousands of you watching, what would you do now? So let's say you maxed out, right? These silly max doses of these antiarrhythmics, none of which are actually true. But you max out at amiodarone, you max out at lidocaine, you max out at magnesium, you max out at procainamide, and the patient's still in persistent VF, but they're tolerating it great, right?
Yeah, I mean, this is, at this point, we're on about hour 3 of persistent VF.
Right.
Just playing on his phone.
Walk into their heart failure doctor's office and asymptomatic, and they could have been in VF for days, right, with LVADs. Yeah. So this is what we talked about. What'd you do?
Yeah, so the uncommon or often forgot about antiarrhythmic of phenytoin was added on as kind of a last-ditch effort. So not a commonly thought of medication for arrhythmia, but it's a class 1 sodium channel blocking antiarrhythmic. So we added that.
Same category as lidocaine.
Exactly. So it's a category 1B antiarrhythmic. So threw that on, didn't work, and then in discussion with the heart failure team, the decision was made to secure the airway and go with defibrillation. But thankfully, the team that we were working with was a very progressive and up-to-date literature-based team, and we just went straight with a double sequence. We did once double sequence defibrillation ×1 and got the patient out. So It was about a 3.5 hour process altogether, but ended with double sequence, which we've talked about multiple times, and it was a great case to see that work so efficiently.
What's the drawback of doing that earlier?
The drawback was sedating this patient. We didn't know kind of how much the RV could take in terms of trying to get this patient sedated. So we wanted to kind of maximize, get some fluid on board, try some other things. And once we got him, because the concern was once we sedate him enough to do the cardioversion or to do the defibrillation, that we could pretty much just put him in a cardiac arrest at that point. So that was trying to hold on as long as we could. Then once we got him intubated and tolerated the intubation well, then we went and proceeded with double sequence.
Right. So, LVAD patients are interesting. We wrote like a clinical pearl about this, about like emergencies in LVAD patients, and then we wrote a clinical pearl, should you do CPR on LVAD patients? And the answer is most people who die after having LVADs don't die of cardiac arrest. They die from their hemolysis issues. So they die of intracranial bleeds, or they die of sepsis, or they die from bleeding in their belly, right? So they die from other things. So it's not typically that cardiac arrest scenario, because they, again, typically do fine. Mm-hmm. But they're always undergoing hemolysis, right? With blood work, you always have to realize that they're always undergoing hemolysis. So do you do CPR on LVAD patients if they are in cardiac arrest? What's the right answer to that?
Depends on who you ask.
I just got one yesterday, and it said, don't do CPR.
Yeah.
You just got one what?
A notification yesterday of a patient, and it says specifically, do not do chest compressions on the patient.
Yeah, I mean, we'll talk about, what's the evidence? What's the evidence? So, this is
CPR.
This is Rochester's data. So Rochester looked at this because the traditional answer has been not to do CPR. Although, again, we're not faced with that situation very often. Traditionally, it's been not to do CPR. But Rochester published their paper that we reviewed, and it's been a couple of years now, where they did CPR on all of their patients, and they had no disruption in any of the lines, right, on the LVAD device. So their recommendation is to do CPR.
Yeah.
But why don't we face this as a more constant problem? Because again, they're typically not going into cardiac arrest. They're dying from other reasons.
I mean, by and large, the study you're talking about was a study of about 9 patients. So it wasn't a large study, but it was still a good enough study to look at patients who went to cardiac arrest, and they looked, and there was no changement in, like, people think about like the LV actually the actual tubing displacing or coming out of the left ventricle.
Right.
That's all nonsense. It doesn't happen. Now, that being said, think about it theoretically, what's actually happening to this patient. This patient has a supportive device for the left ventricle. So if you're in ventricular fibrillation, both ventricles are fibrillating. So what support does the right ventricle have? None, right? So, right. So the issue is that you get some suction volume, like Jim's talking about, from the actual device itself, from the LVAD itself, but that's about it. So there's no forward flow. So if you have someone in VFib, you need to give the RV some support. So there is some utility in doing chest compressions to a patient with an LVAD because you're giving the RV forward flow, which again is preload, right? So you're giving that forward flow, that preload, so you can actually, fill the actual LV. So now you can actually have good cardiac output. If you have no good cardiac output, you're done. Now luckily, your patient must have been sustaining pretty good flow.
Yeah.
That's why, they were tolerating the actual VFib well. And most patients do well. The patient you don't ever touch in VFib is the patient with the BIVAD, right? But we know that patients with BIVADs never leave the hospital. So we won't ever see that patient in the pre-hospital setting. But patients with LVAD can. And that's the patients that we really deal with.
And usually with the LVAD, you either have destination therapy or bridging therapy, bridging to like either a transplant or another device. And the reason why they always said don't do CPR is because you're worried about dislodgement. That's what he was saying with, and we just don't see it.
Could it be device specific on dislodgement?
No, what are we at the HeartMate 3 now? Going to go on the HeartMate 4?
Yeah.
No, I mean, the devices are getting better and better. I mean, the future is the devices get smaller, and soon you'll be able to swim with them, and do like everything with them. Because you can't get it wet because there's only like one component. Otherwise, you could. But the future is, when these all started, you couldn't leave the hospital, right?
Right.
And it was like a big bulky thing, and now it's getting more and more portable. But no, I think the thing is we don't face this situation that much because of how the LVAD works.
Will the LVAD maintain circulation even if they're in cardiac arrest?
Yeah. So this is
Even
why
though
most people.
you said there's no right ventricular support.
So if we had an LVAD patient right here, right now, if they're asymptomatic, I know they're not in cardiac arrest. I mean, my friend tells me, he goes, Mark, we get these guys all the time. They walk into my office and they're in VFib.
And you just
Right.
shock them, or
And I said, what do you do? He's like, I give them an antiarrhythmic. And then what? And then they break. And then what do you do? And I send them home. Right? And
I mean, there's a reason why they're on LVAD. I mean, they have significant cardiac systolic dysfunction. You know,
well, he
even
said you
diastolic.
can't hurt them.
Right.
You know, it's interesting. He said, I do all these consults for all these people like who need their gallbladders out for LVADs. And I always go to the chart and I write, you will not have a problem for sure during surgery. Right? Because it's hard to mess something up.
Right.
You know. Again, they do have a volume-dependent issue. So, you know, in an emergency setting, most of the time you just give a fluid bolus or two, and that cures
Right.
all their ills, right?
Right.
And then you check for, you know, aortic insufficiency. You know, in the ER, we'll just grab an ultrasound machine and look for one of the 13 signs of aortic insufficiency. What's it called when your head bobs? What's that called? Who's interviewing today? Head bob? What's that called? So you see somebody head bobbing as a sign of aortic insufficiency. What's it called?
I can't think of it.
Man, what if a patient comes to the ER tonight and says, quick, I'm about to code, what is that called when my head bobs?
I was a.
It's not,
I was a hint.
hankies, pulses.
No, but you're thinking. It's called de Massé sign. De Massé sign. What's this called when you grab your chest like this? This is too easy, right?
Starts with an L.
Yeah, Levine sign.
Oh, Levine, yeah.
So what else happened to your guy?
Oh, no, he just hung out. He was VFib into the 250s, and then after the double sequence, it did great. Heart stayed in mid-90s, did fine.
I'm sure somebody's at home saying, well, why don't you just try single defibrillation? They had an LVAD in, maybe it would have worked. What would have been the bad thing about it? Because we normally don't do double sequence first.
I think the heart failure teams. I spoke with the transplant attending, and their thought was because it was so refractory to every antiarrhythmic that they just wanted to get it done, and their thought was the more juice the better. I think, and it was a training institution, so having
Also, the more vectors.
yeah, so they
Right.
wanted to guarantee they were going to get it done essentially,
All right.
and they said with double sequence, we know that with that much juice, it's either going to work or it's not.
So along the same line, Dr. Schreibman, who's the medical director for Inglewood Hospital, came up to me at a recent conference and said, listen to this story. We had a 34-year-old at Inglewood, and we've been reading about what you wrote about double sequence fibrillation, so we're about to institute a policy, but we hadn't done it yet. We had a 34-year-old patient go into cardiac arrest. We did 8 single defibrillations, and the paramedic, before the policy was written, did a double sequence. She called to the console doc, who never heard of it, right? But he said, sure. She did 1 double sequence, and the guy converted. We were about to pronounce the guy dead, right? Pretty cool. And the paramedic just said, you know, I read about this, so I decided to do it. And the cardiologist never heard of it. Nobody in the ER had ever heard of it. And then the guy sent pictures to her of like him barbecuing with his little kids, right? Who would have been pronounced.
So you barbecued them first, so.
Yeah.
So pretty cool. Who else has an interesting case?
We had a middle-aged male the other night who presented. He was at a cardiologist's office. He was complaining of shoulder and jaw pain upon exertion the last couple of weeks. Went up for a stress test, ran into a run of VTAC, and showed 5mm elevations in 2, 3 and AVF. By the time we got there, everything resolved. He's pain-free. He's back in a sinus rhythm. So we met them actually en route going to the hospital. He had received 324 of aspirin from his doc. We popped the line into him, and we started going to the hospital. What we weren't sure about is this a STEMI alert? So that was our question, and we called ahead, and we called it as a STEMI alert. I called the doc back after our consult with you, Dr. Merlin, and we got to the hospital, and the first question they asked was, "Is there any chest pain?" Now there was never chest pain. He never gets chest pain, and they downgraded a little bit. He ended up going to the cath lab and got a couple of stents.
So what would you guys have done, right? So you're called, and so somebody, you know, gets on a treadmill, gets to a Bruce protocol, they have SE segment elevations, and then EMS gets there, and they do another 12 lead, and there's no elevations. Would you have that ER called as a STEMI?
We had the original 12 lead from the doctor's office.
And it was an impressive,
Right.
from what you described
Yeah.
to me.
Yeah. It was 5mm, and you saw his run of VTAC, you saw everything there, but now it resolved itself. So we're there, of course, just in case something happens. And when we get to the hospital, and this is a question that's been presented by many hospitals, the first question they ask them, is there any chest pain? Now, we know that you don't have to present with chest pain while you're having a STEMI, but hospitals don't always do that, and they end up downgrading it, and now the patient sits out for a bit. I don't know that that's wrong. I'm just concerned what, I'm just wondering what you guys would do if somebody presented with either a resolved STEMI or a STEMI without chest pain.
I mean, the problem is some EKGs can have, sustained ST segment elevation for long periods of time and be like other things like myocarditis or ST segments can never resolve or can look like left bundles. So that's why people say you're having any chest pain to just try and figure out how acute it is, or they grab an echocardiogram, an echo and just see if the walls are thinned and if there's wall motion abnormality and stuff. But I decided to call it a STEMI, right? Even though the ST segments had normalized, right? Because maybe he was having spasm. Either way, he's probably having a fixed lesion and having ischemia. Sounded like a good case, right? I mean, if you go into vasospasm, you can still make troponins, right? If you're in spasm long enough, you can have myocardial damage, right? And I tell you, I keep being told by interventional cardiologists about cases they've had where like the troponins are 80, 100, and they take them to the cath lab and the coronaries are clean. And why is this? The answer is they're probably just all having myocarditis, right? And with big tropes, right? With normal caths, right? And I told these guys today at lunch. I had a guy who was 70 years old from Monmouth who was on a plane at Newark Airport, got some chest pain, and we did a stress echo on the guy, diffuse wall motion abnormality, mostly his anterior wall, global ischemia, goes to the cath lab, cath is perfectly clean.
Yeah. I sent you that patient.
You sent me that picture? Yeah. So, thank you. So, a nice freaking guy, the echocardiologist even said most likely triple vessel disease, right? Which he didn't know. He did a stress echo.
Yeah.
And I'm like, preparing the guy that, this is probably not going to be a simple cath, blah, blah, blah. And, and I read the cath report right afterwards, and it's like normal coronaries, false positive echo. And I'm just like, wow. And why did I get a stress echo? Because it was like a Sunday night or something, and that was what was available. That's why I got a stress echo.
At the end of the day, you still need to cath these people. I don't think,
You still need to cath them, but it's an urgent cath versus like code STEMI cath
Right.
right away.
So I agree. You need
Still
to
gotta be done
cath
before
them.
that.
So what if you had done a nuclear test, which would have been negative? What if you had done a CT with coronary arteries, which would have been negative?
There's always going to be down in your mind for the non-invasive studies. At the end of the day, you still got to cath.
Right. Because as we've all been taught, nuclear tests lie. Right.
I mean, it's all
Right. No, I think
non-invasive.
this guy would totally appropriate to send to the cath lab, but I don't know how many such false positive echoes I see, stress echoes, right? Maybe a little bit, but global hypokinesis.
So never global. You would see like a
Like
certain
a
aspect.
question, right?
Maybe some attenuation or something that you usually see, maybe secondary to like obesity or something, but never global. I've
Right.
never seen that.
I mean, we're all okay at echoes, and we all learn there's clearly some subjectivity about doing echoes between one person to the next, right?
Certainly.
But the guy who read this was an echocardiologist, right? Who sits in a dark room all day long, does nothing else but look at echoes. He's pretty good, right? And he wasn't just calling questionable one wall, abnormality,
It's a definitive report.
huh?
It was a definitive report.
Yeah.
Yeah.
Yeah, right. How often does somebody write through most likely through vessel disease based upon that stress echo?
Right.
It was that impressive.
Yeah.
And it diminished EF, and it was all just wrong.
The first rule of checking that scan is read the name on the top of it.
Right. What other interesting cases do we have?
What's that?
So I had one recently. It was a middle-aged male. So we were dispatched for a report of a burn victim. So we arrived on scene, and so this gentleman was pretty much in distress at that time. We had established IV access, and he was getting fluids at that time. But pretty much he had thrown denatured alcohol onto a bonfire, and so it had flashed backwards, and pretty much he had caught himself on fire. So it was interesting. He had probably, I want to say, 5% full thickness to his right lower extremity with surrounding partial thickness, as well as he had partial thickness on his left leg, as well as extending up his right flank. So we estimated the total surface area was about 45%. So again, I think what this highlights more than anything is because he was in distress is the need for pain control in these patients and how difficult it is to achieve that. So I know that he had gotten like 6 morphine, he had gotten plenty of fentanyl, as well as we had used ketamine as well. And so we still weren't achieving, I guess, our desired goals of, relieving this gentleman's pain. So we ended up just doing as much as we could, and we ended up just transporting him to the burn center. But I think it just highlights the utilization of ketamine, I guess, in these patients, and the role of dissociation as well for pain management.
So, so we have pre-hospital standing orders in New Jersey, so for fentanyl or morphine, you don't have to call in, right? You can just give it before you contact medical control for pain. It actually, the preliminary stuff started with burns, right? And most of us in New Jersey for pain, we give fentanyl for everything, right? Even for chest pain, it's no longer, Mona, it's Vanaway chest pain, right? Because we believe that morphine decreases Plavix absorption by, the study we reviewed showed 30, right? Is there anything we're not giving ketamine for?
Chest pain.
Oh, no, that's lidocaine. We can give.
Oh.
Right, because we're also doing lidocaine for pain too. We also have a protocol lidocaine for pain. Is there anything ketamine can't fix?
I know, right?
Ketamine and kale, they can fix everything. So
Ketamine for non-traumatic pain too, or just traumatic pain?
Yeah, we're giving ketamine for abdominal pain as well.
ketamine for sickle cell pain, ketamine for like any pain, right?
Kidney stones, gallbladder.
Kidney stones,
Yeah.
gallbladder. Yeah.
Pre-hospital as well, correct?
Yep.
That's in the
No,
protocol.
I'm just saying, right?
Pre-hospitally, probably even more so than the ED.
Yeah, I feel like it's more important for the pre-hospital provider because they're, we're very limited for our paramedics on what they can carry and what they use.
I mean, some people with pain need to dissociate. I mean, the guy who, ketamine is still the primary drug you do for field amputations,
Oh, yeah.
I mean, if your leg is chopped off, dissociate the guy, it's okay, right?
There's a myth out there that if you give pain management for somebody with abdominal pain, then the ER doc can successfully evaluate the patient when they get there. That's pretty absurd, correct?
Yeah, no,
Absolutely.
this was a concept like in the 80s. This was a concept popular in the 80s, and then there were 10 studies. I used to carry them around with me before all these computers to show people like you're totally wrong. Here are the studies. That's when we used to all give morphine for abdominal pain, and people will come along and say, it's changing my exam. But it's not true. It doesn't change peritoneal signs. There's lots of studies to suggest that. And I think, in those days, life was different because we didn't CAT scan all these people with belly pain. We figured things out clinically, to the detriment sometimes of the patient, right? Because a much higher percentage went to the OR who for appies who did not have appies, right? And now we figure stuff out first, unless they come in and they have like overwhelming peritoneal signs. Like before I got here, somebody just called me about a case they had where they looked at a guy in the ER, he was writhing in belly pain, they got an upright chest and he had free air in the diaphragm with peritoneal signs. So he looked sick and he went right to the OR. And I'm like, fantastic. No imaging, no blood test. Somebody just took him and he had a huge perforated anterior gastric ulcer, right? So a good case. And it was somebody who didn't want to wait 10 hours for a CAT scan, right? But it does not change your exam. It does not change your exam. It does not change your exam. In 2018, there is no reason I don't get people something for pain, right? Do you guys, everybody agree, right? I mean, no matter what's the source of your pain, sure. If your blood pressure is 60, I'm very, very cautious, right? So I'm trying to give you something that's more neutral. Hence, maybe some ketamine, right? But I can't think of any reason I don't give somebody something for pain, no matter what. And sometimes it's oral. Listen, if I'm planning to send you home and I don't think your pain is, I guess I shouldn't say that. I mean, listen, sometimes people have, headaches, and I'm not giving them anything. I'm giving sphenopalatine ganglion blocks, and stuff like that. So, but that's indirectly for their pain.
Yeah, like if you think about it, if you fracture your arm and you give them morphine, when you press on their arm, it still hurts. They're just more comfortable now. So that's
Even if you press and it doesn't hurt, they still have a fractured arm.
That's true.
it crunches a little.
Is anybody getting pushback from anybody with pain? You're all trained in different programs. Anybody get pushback for pain?
I don't know if you guys seen this clinically, but a lot of people, I see them in the ER, they have a painful complaint, they rate it greater than 4 out of 10 in their complaint, you offer them pain medicine, they're like, no, I'm good, doc.
Right.
You're here for a painful complaint, I'm here to give you pain medicine. They don't want to find out what the reason of the pain was. I've seen that more and more. I don't know if it's the mainstream of the opioid crisis and nobody wants to get addicted or what.
Right.
I mean, I'm seeing that a lot more.
But we have, but as we said, I agree, and we have, good doses of subdose dose of ketamine or lidocaine or you know.
Altered is still narcotics,
Right.
Are we ever going to see liquid Tylenol or IV Tylenol?
No, you know, I present. I mean, this is what Massachusetts did, right? And I mean, I presented this data at the state meeting. You know, the study was academic emergency medicine, which did looked at all the studies on IV Tylenol, and they were all so vastly different. You know, and they used different parameters, different endpoints, and many of the studies were terrible. Like, not that they were terrible statistically, but they did not show good results from pain control. So, I mean, the flip side is it's a pretty benign drug. However, it doesn't tend to work very well.
What about IV NSAIDs?
Yeah, so IV Toradol, the problem is pre-hospital, you have a bunch of septic patients, they're volume depleted, they're renally insufficient, they've potentially been in a nursing home for a day or two, and maybe they're going to acute tubular necrosis, and we're going to hurt their kidneys by giving them a dose of non-steroidals.
But that would, Toradol would be the worst for that, like 60 milligrams of Toradol. But how about if you went with an ibuprofen IV? Is that possible?
Well, I mean, Toradol is essentially IV. It's the only Toradol is the only IV non-steroidal we have. But no, but PO non-steroidal. I mean, I won't give somebody a PO non-steroidal if they have renal insufficiency chronically and were eubulemic, right? For that matter, by the way, I wouldn't, and we discussed this, and I know Josh, you know this. I wouldn't give somebody who's having chest pain a non-steroidal besides aspirin. Certainly because there's a recommendation by the American College of Cardiology against giving non-steroidals besides aspirin to people chronically who have cardiac disease, right? Because it potentially makes them worse. And despite that, people will still give non-steroidals to elderly people who are discharged with, you know, ankle pain. And Tylenol is just as good. What's the most common drug you should give for osteoarthritis? Tylenol. What do most people get? Non-steroidals.
And they'd be giving COX-2 inhibitors, which also cause the same cardiac issue.
Right. And all the non-steroidals are roughly the same. They're all potentially bad. Right. Other interesting cases too. Did you? So the burn. So the burn got fentanyl, morphine. So they switched up.
So initially he was given 30 of ketamine, and then he was given another 30 for a total of 60. He received a total of 200.
What do you guys think about that?
No, he got 60 of ketamine, sorry, and then he got 200 of fentanyl, and then he had 6 of morphine as well.
So typically the max dose, so let's just talk about the paper. In the paper we just reviewed, the max dose of ketamine was 30 milligrams. That's the maximum for pain.
How much did the patient weigh?
In a single dose.
He was 61 kilos.
60.
It was
so
30
small.
times 2.
Yeah.
30 and 30.
It was 30 and 30. Okay. I see. It's 30 max per dose.
Yeah, it was 30 and 30.
Okay.
Yeah, it was,
Okay, that's different.
Okay.
So he got 30 and 30. Because in the paper, they gave max dose of 30, and then they switched to fentanyl as a rescue, didn't they? Right.
Yeah. Well, what's interesting about that case is it's like 0.3 mg per kg is the dose that we're looking at, and in this case, it sounds like he was so small, I guess, that you almost gave him a dissociative
That's
dose.
true.
because we weren't managing his pain whatsoever, so
Right.
we tried increasing the dose of that.
Right, but now you're not subdissociative anymore.
Correct.
So
Right.
now he's.
So now the question is, what's your goal? Because how much fentanyl did you give?
I believe it was a total of 200.
Yeah, and what was his pain from?
It was just from burns.
It was from burns.
45%.
Yeah, it was significant.
Yeah. So, you know, at some point you just go, probably time to dissociate the guy, right?
Yeah,
'Cause
I mean, that's what we
he's
were
suffering.
talking about, yeah.
You probably need more fentanyl. I guess you could have tried IV lidocaine. I'm not, no.
We talked about that actually on the way up.
The other thing is, you know, I mean, a lot of burn places are very in vogue with giving benzos for years, right? Give the guy a little benzo, take the edge off. I'm not sure it would have mattered a lot with all that ketamine on board.
We ended
but,
up giving 2 more of Ativan actually after we talked to the burn center.
Right, because they like benzos.
Yeah.
What? Anything else you guys would have done? I mean, the guy's probably getting close to being intubated, right? And just
Yeah,
to
he
take-
didn't have. I mean, that's what they were talking about once we actually
Just for
got
pain
to the
control,
emergency.
nothing
exactly.
else.
Yeah. But other than that, I mean, he didn't. It wasn't. His airway was intact. I mean, there wasn't any burns or anything like that, so there wasn't a necessity at that time. It was just for pain management, I believe, is what they were talking about.
Yeah, pain management, but also like for the little bit of amnesia, you know, you don't want to
Yeah,
remember 45% burns.
Yeah.
Right.
All right, let's do the articles. Who's got the first one?
We can talk about the backboard one if you want.
Oh, the backboard article. So, I didn't know how I felt about this initially, but I think that, oh, go ahead, it's all yours.
I mean, so the article was looking at a protocol change that occurred in New York back in 2015, where they originally had set up a protocol that said basically anybody that could have a spinal injury has to be put on a backboard. And then that was their spinal immobilization protocol, and they changed it to their spinal motion restriction protocol, which was the backboard was optional, and it was the study looked at whether or not changing the protocol to make backboards optional changed how often the patients received thoracolumbar CT scans in the ER. It was kind of interesting, an interesting thing to look at and think about, like working at a trauma center versus not trauma center. But essentially, like all the subjects that they looked at were like similar. They looked at before and after the protocol change, like similar age, gender, and they all had to be involved in an MBC. There were no peds involved in the cases or in their accepted patients. They had 54% backboard utilization in the before period where the spinal immobilization was the standard protocol, and that decreased to 35% afterwards. So there was a big decrease in the use of backboard, but the lumbar spine imaging, it didn't change as much as I thought it was going to. So they had, I'm sorry, I misquoted. So it was actually went from 54% to 12% after people using the backboard. So it was a huge decrease in use of the backboard. But the T-spine CT scan, they did 35% of the subjects had their thoracic spine CT'd when everybody was coming in on a backboard, and then after 30%.
What was the first number?
So it's 35% when everybody was on a backboard, down to 30% when not everybody was on a backboard. So it didn't decrease by as much as I thought it was going to. And same thing with the lumbar spine. They imaged 41% of the people before they changed the backboard to being optional, and 35% afterwards. So it decreased by 5 or 6% on both imaging the T and L spine. But the article went on to talk about how they're wondering if using the backboard actually changes the physician's perspective of how injured the patient is, and if the medics in the field think that they don't need a backboard, are the physicians in the ER going to be less likely to subject them to radiation and get a CT scan? But I think it's kind of convoluted in that most trauma centers do, and they actually mentioned this, like the PAN scan, like the trauma scan, where they go from head to toe, and you can do like a reconstructed image of the spine using a CT scan of the abdomen and pelvis, and so most of them end up getting the CT scan as a part of their other imaging anyways. So it's a little bit hard to interpret that statistic, I think. But overall, their conclusion was that decreasing the use of the backboard in the field decreased the use of the CT scan in the ER.
Right.
To image the T and L spine specifically.
But not by much.
Right.
We always talk about, or I always talked about, like, EMS has always said, do you want me to show you a picture, doc, of what the accent looked like?
Right.
And my answer is always, not in a million years, because how else do I justify doing nothing for the patient, right? You know, that would be a great study. You know, we randomize people to either see pictures of the accident scene or not see pictures. And the people who see pictures will order a lot more imaging. Don't you guys think? Because now they'll go, oh my goodness, the guy looks great, but look at how bad those cars are.
Yeah.
So I bet just doing that will show us more. And yet some people like always want to take pictures of the accident scene.
Well, especially now that the cars are so much more protective, like there are crush zones. The car can look completely demolished, but the actual patient compartment is the passenger compartment is completely untouched because they have the firewalls, the crush zones.
Because the Nexus trial way back when, the mechanism was not included, right? So we feel very good. The car rolled over, 20 times, but we're not going to do anything for the patient.
And they actually talk about that in here, about how the C-spine, we have like 2 pretty well validated decision-making rules for clearing somebody of their cervical collar, but the T and L spine is very subjective, and it's based on mostly gestalt in your physical exam, and so that makes, I don't know that you're ever going to really be able to get a true correlative percentage of people with or without the backboard, because it depends on the doctors.
How you handle traumatic back pain totally depends on where you show up.
Right.
Right?
Mm.
Right? Have we done anything good or not?
Right.
I don't know. It decreased it by just a little. I find that hard to believe. I mean, I don't know.
I thought that the point that they were making with the lead up to the statistics was that, which makes sense to me clinically, if you put somebody on a backboard, it is going to increase their pain. Those things are incredibly uncomfortable. So even if they just have like a muscular strain, and then you make them lay on this hard thing for even just 20 minutes, it's going to make them stiffen up, and it's going to be uncomfortable for them no matter who you are, young or old or in between. And so then when you take them off the backboard and they say, oh, my back hurts, is it now worse just because they were laying on a hard
backboard? And I was honestly, I said, no, I don't want to put them on the backboard. I said, I'm not going to roll this patient and do all this nonsense to put him on a backboard that he's not already on. And it was a little bit of pushback, and I felt kind of having to explain it a little more than I expected, because I feel like we kind of beat this topic pretty good. And I said, I mean, we have plenty of evidence to support why are we doing this. And I guess some places they go, the trauma team still wants suspected spinal injury on a spinal board. But I mean, they'd already been through a 10-minute ambulance ride, now another 25-minute flight. I just didn't see the need to do that. So I mean, I don't know if anyone would disagree with that. But
Well, the one problem is some of the flight teams, they have to be on a backboard in order to be loaded. But they got rid of that?
So not for
We got rid
us.
of that.
Okay,
Yeah,
awesome.
we got rid of the one helicopter that required it.
Okay.
I know ours doesn't
But,
require it.
you know, find me the person who says the patient still needs to be on a longboard, and we'll talk to them.
That's not what I
Because
said.
for all the people who say, I'm going to complain about this, I never get any complaints about this anymore from anyone. We get complaints about lots of stuff, right? But not about this issue. But even when you're using that backboard as a pelvis, a splint for a pelvis, I mean, how many people do we see who are hypertensive with pelvic fractures who have no teapot on or no, circumferential sheet, and yet they're using the longboard for a splint, right? I'm like, it's not right. You don't get circumferential pressure from a longboard. I know that for sure.
I think it's interesting that just coming from Chicago to here, that they actually use longboards there a lot more than I've seen here. And I'm not sure why. I don't know if it's because they have a very short transport time, and they have a lot of like pedestrian versus, car accidents in the city or whatever it is. But I distinctly remember the majority of my trauma patients who were involved in like an MBC coming in on a backboard, and then we would obviously take them off the backboard right away when they got there, but then in order to image them, like with the trauma team, they lay on a flat, like a hard bed that has like holes cut in it, so that they can slide the x-ray things underneath them to take pictures. And so like we're moving them from one hard bed to another hard bed, and I don't know if that is much improvement.
This is perfect. You can fix Chicago.
Yeah.
When you go back to Chicago, there's lots of opportunities to fix it, right?
Yeah,
If they were doing
interesting.
things perfectly, like, you wouldn't have much to do.
Yeah.
Yeah, I don't know. You still see this, right? What's people's experiences with other states or other cities? Some places you get no cervical collars, we know that.
Right.
And no longboards, and I don't know. We all do things.
Between the EDs and EMS. I know where I trained, that was not the case. It was rural EMS, lack of education. Medical directors were off-site, kind of really not involved. They would do their basic requirements of chart review, and that was it. And never provided the paramedics with education about why we are or are not doing this. So I think it's a change of behavior, involvement of medical directors in the system, I think has a lot to do with it as well in some places. New Jersey's different.
I was in Rhode Island not that long ago, and I gave a lecture to a couple of counties, and I said, you guys should all just stop using longboards and doing this. The state medical director was there, and one of the paramedics said, can we do this? And he goes, it's not under regulations, you can do whatever you want to. Right? And that's how people learn. They hear about something from somebody else and they just start doing it. Right? Many states, unfortunately, are not like the top down, like a protocol, let's just do this.
You're going to still see exceptions. Just last week in a busy community medical center, I was still called to the bedside of a clear signal medical person, an old lady off a backboard who fell. Who came in on a backboard with a C-collar and probably a fractured hip, and on a backboard, fully immobilized, head to toe, in pain. I'm still called to the bedside to clear her or off the board.
Right.
That was the first time in 6 months that I've seen that.
Right. The only answer is, and it's not very easy, is to find out who put the patient on the longboard and just say, you guys don't need to do this. But of course, that's challenging because sometimes by the time we get to the bedside, the crew's already gone. Or you have 20 other patients, you're trying to deal with.
But in a busy emergency department, you're half hour, 45 minutes, an hour, somebody laying on the backboard, that's where all these problems start.
Right, and now the patient's really in
Still
pain.
happens.
Yeah.
Right, and now your little lady played a lot of pain, and now you're going, what was from the longboard and what's from real?
it's not that they don't need to do it, they shouldn't be doing it.
Yeah.
Scoop, like, how would be better?
Yeah, but
Get an old lady up off the floor that wants to do it.
Is there a time when you would use a backboard? Like absolutely, like if you had somebody who was involved in MBC and they have like obvious neuro deficits where they can't feel their legs or they can't move their legs, still no longboard? Because I think I'm trying to think of the patients that came in to the trauma centers in Chicago, and I think it was because like in their mind they were like, well, if we're calling this a trauma and we're taking it to the trauma center, then we should immobilize them. And I just don't know how do
I
you.
mean, we put up
do
all
that thought
Sabrina's
process.
videos on our website, but
Well, remember, in neurosurgery, you know, even with a transected spine, you put them on long rope precautions on a bed, not on
Right.
a backyard.
I mean,
Right.
what do they do after they diagnose them with it, is the question.
They take off
don't have
backward.
They don't leave.
Right, they just lay flat. They don't like.
Right.
Right. No, I agree with you. I'm just wondering if
I mean,
there
to
is
me,
any-
extrication, sure. You want to extricate somebody from a car using a longboard, sure. And then the
Yeah.
minute you get them on your stretcher, then you take the longboard off. And if
Right.
you're in Japan, you take it off via the head. And if you're in other countries, you do a log roll. But however you do it, and if they have any neurologic deficits or distracting injuries, you leave them flat. Otherwise, you sit them up. It's somewhere between 30 to 40 degrees.
Yeah.
You know.
I'm
And
trying to think of a time I would want to
Yeah, you
use
think
it.
about that
Oh,
obese
well,
patient
that
that's never laid supine in their life, and you got them supine on a backboard strapped down.
Right.
What are you doing with that patient?
Right.
A lot of BLS ambulances will still carry longboards just for the purpose of carrying a hair traction.
Right.
So
But
in
you're,
that
I mean, you're required
circumstance-
under the state.
Exactly, so
statute.
that's like the only circumstance I can think where someone would put someone on a longboard purposely, is if they wanted to use a hair traction at the same
Right.
time. But as we know, there's multiple devices out there that are much easier to apply, but.
When's the last time anybody here put on a hair traction?
Exactly. We actually, on my BLS ambulance, we carry this, and I'm
EMT
not
test.
endorsing. Exactly, EMT test. We, I don't endorse any company, but we use a device called the Sager splint, where you can actually immobilize both limbs at once if you happen to have bilateral femur fractures. It's kind of like, it's very simple to
Right.
apply, and you don't need the backboard, which is another convenience,
But you never put a hair traction on in the emergency department after you knew they had the fracture.
Exactly.
So all those hours I wasted at
So
the
silly.
squad on Friday, Saturdays, putting on hair traction on short boards. I could have been studying like the Krebs or something like that.
Yeah. Don't forget about the CAD.
Oh, and the
Put that on
CAD,
too.
the CAD. jeez. All right, next article.
Who wants to go over Reboa?
Alex
I'm
is
gonna
up.
vote again this week. I'm up. Let's see. There we go. So Reboa. This will be another one. This will be another article out of University of Maryland Shock Trauma. We reviewed an article last week about using Reboa and how one of the keys to it is being able to get percutaneous access into the arterial vasculature. ER docs are great at it. We do it all the time. So is this something that can be applied? This article, so that more kind of looked at the use of Reboa. Is it feasible? What were their? They weren't necessarily looking at outcomes data. Just hey, what did we find with the stuff that we used? Looking back at it, this is actually looking at more of the technique in terms of how's the best way to put in the Reboa device so that you can still get an endovascular intervention. So this is more of a techniques paper.
Alex, just tell us who the first author was and where the study was out of.
So this is University of Maryland, shock trauma. The first author
So
is
your future home.
Yes, so my future home. So obviously Dr. Scalea, the king of shock trauma, is on this paper as well. But the lead author is it doesn't say specifically it's a medical student or it's a Saqib Adnan, looks like a Bachelor of Science. So hopefully a awesome medical student who's really into Reboa and will one day be an EMS fellow.
So we wanted him to apply to our fellowship.
Yes, so hopefully one day an EMS fellow, so I'll start recruiting when I get down there.
All right, good.
But then it has a lot of trauma surgeons that are part of Shock Trauma Center, University of Maryland faculty. And so again, done there, major trauma center, they see more trauma than they know what to do with. And essentially this is a procedures and techniques paper, so they're talking about, this was more focused on the zone 3 injuries. So zone 1 is going to be your intrathoracic, so it's actually defined as from the origin of the left subclavian artery to the celiac artery is zone 1 for Reboa, and zone 3 for the Reboa is from the lowest renal artery to the aortic bifurcation. So this is actually looking more so at zone 3 injuries, and So it says infrarenal resuscitative, or pretty much infrarenal Reboa is an adjunct to control pelvic inflow, while you want to sustain the circulation so that you can actually get hemostasis. And what is becoming more and more standard of care is endovascular angioembolization. So the question becomes, when you place the Reboa catheter, are you then going to have difficulty getting endovascular treatment performed at the same time? And it says with the balloon catheter at the bifurcation, it can prove difficult to navigate catheters and wires past that in order to be able to achieve your intervention. So that's kind of what they were looking at, was what's the best way to do it. So they talk about, they've been using it, shock trauma, since 2013. They've been using Reboa in clinical practice. So they've been having this all the time. Something else of note at this institution, which I'd say 95%, if not more, don't have, is they have a dedicated vascular trauma team that will assist with and they are trauma surgeons that are also vascular trained surgeons. So that's all these guys do. So that is a little, I mean, if they're having difficulties with this, I can only imagine what we would do. But essentially they were thinking, when you just think about endovascular, or angioembolization endovascularly, access, angiography, intervention delivery are the things that you need to consider. So access is what we would do. The angiography and intervention delivery would be the interventional guys or the vascular team. So what they focused on mostly was the actual Reboa technique. So they said that in their institution, all patients with evidence of pretty much infradiaphragmatic hemorrhage were considered for Reboa, and that's with a positive FAST exam and no evidence of intrathoracic injury. And pretty much life-threatening pelvic hemorrhage with imminent cardiac arrest. These are the patients who would get Reboa. So they would pretty much use ultrasound guided, because these people usually have clamped down vasculature. Ultrasound guided access is what they did most often, and then they used actually plain radiography most of the time for confirmation of placement in terms of where the balloon is actually in what zone. So they talked about different ways: ipsilateral common femoral, contralateral common femoral, and then they talked about the upper extremity techniques. So essentially, ipsilateral common femoral access is the least common, and essentially you end up having to deflate and remove part of the Reboa balloon in order to get your endovascular intervention accomplished. Therefore, it's not really it's very difficult to perform, just because you have to, if you're in a massive hemorrhage situation, by the time you deflate the balloon, it's going to be difficult to achieve hemostasis. So it's not something that's very commonly done. But they did discuss the contralateral common femoral access approach. So it says the endovascular approach, so it's the most common, where the patients can't tolerate balloon deflation, so you have to leave that balloon inflated, but still be able to access the bleed, so you can do embolization. So you cannulate the contralateral common femoral artery. So they talk about using either venous cut down, arterial cut down, or ultrasound guided. I don't know of many residency programs where you get the training to do a surgical cut down over the common femoral artery. This obviously is a trauma center, so they do this quite frequently, because this trauma center is staffed by trauma surgeons, not emergency department attendings. But the one thing we are very good at as emergency physicians is ultrasound guided access. So that's what they recommend doing. And then they talk about using different types of sheaths. A 5 French introducer sheath, really you can do a lot of things with the 5 French sheath. They go into a lot of detail about what type of wires and all this kind of stuff. But essentially, the contralateral femoral is where you can get is the most well tolerated, and then you pretty much, your endovascular team, your job is to get this in, get the balloon inflated, and then this makes it easier for the treatment team to get done what they can get done. Then it talks about using upper extremity access for Reboa, which I never in a million years would, not for Reboa, for endovascular treatment. So I never would have thought this, but you have patients in pelvic binders, difficult to access it, difficult injuries, Reboa is already deployed. So using the upper extremities, just like they do radial artery catheterizations, to actually access the pelvic vasculature and do your technique from there. One of the things they talked about was obviously the radial approach is the most common. They have been using it for over a year without any significant morbidity or mortality. of when it's described, the left radial is the shorter distance. However, ergonomically, in terms of the way it's set up, it's actually more difficult to perform. So commonly, they're using the right radial artery. And it says that an antegrade approach from above actually makes it easier to access the iliac arteries. It makes it pretty straightforward as compared to the retrograde flow when you're cannulating from the femoral arteries. So essentially what they pretty much looked at was the actual technical considerations of REBOA and making sure you're in the right zone. There are some of the REBOA devices where you don't need, I mean, it goes based on measurements, not necessarily imaging, but really getting the balloon inflated and working with your endovascular team in terms of what the best way is for them to be able to perform the definitive management of the intervention delivery is what they called it. So it says upper extremity access can be a useful way of avoiding it, but you need specialist equipment and limit some interventions because of the size of the catheter you can actually put in the radial artery is limited. So if you need a bigger catheter, you're not going to be able to do that through a radial approach, or more so like for stent deployment, things like that. So essentially it says the route of access you choose should be really based on patient factors and what your clinical capabilities are at your institution. The goal is still to get this done as timely and efficient as possible. From what I took away from this from an emergency and EMS standpoint is that we just need to make sure that the balloons are in the right place and we just say, hey, this is where we went, this is why we went, this is how we got there. And when they do confirm placement at the receiving institution, or if we're in an emergency department setting, confirm that the balloon is in the correct zone. What happens when we deflate the balloon? How difficult is it going to be for them to be able to get their catheters in to be able to do the endovascular treatment? Because are they going to be able to go on the contralateral or ipsilateral side, or do they want to revert to the upper extremity? So that's not something that we would typically be doing, so we're not deploying the definitive intervention where we are deploying the REBOA catheter and inflating that balloon to stop the massive hemorrhage. So,
Right, so as we continue the discussion to get REBOA pre-hospitally, you guys should put in as many common femoral lines as possible, right?
Mm-hmm.
Because that's why Holcomb wants to come here and go over this with us in trauma, so we can keep doing this over and over again. And so for me, I mean, do it during cardiac arrest. We all talk about, we got A-line capabilities in the ER at North Beth to do this, so you can do A-lines. All the nurses got trained. So some people do it, some people don't do it, but do common femoral so you can practice for REBOA in the pre-hospital setting. Right? That sound good? We should keep reinforcing that.
yeah.
And
I feel like I don't know, different places are a little bit different, but you get a lot of pushback when trying to get any kind of vascular access in the groin. Even for central venous catheters, no, you can't do anything in the groin. I can kind of do whatever I want. I can put it wherever it needs to be. But that's what I was saying. I think there's some institutions, and I think that it's just something that we need to do, is just as from an education standpoint, is to provide that as to why we're choosing one site over another.
When I was up at not to mention hospital needs, but Barnabas, the team, they're perfectly fine with anything in the groin. They're converting.
Mhm.
Put dialysis catheters in the groin just for them to go to dialysis. Everything.
Yeah.
right. But it's also because a lot of people are coagulopathic, and you got a compressible vessel in the groin.
Yeah.
So we put everything.
I mean, how many times have you guys put in A-line? That's what they're going to ask us. How many times have you guys put in femoral A-lines? And how often, so, because obviously somebody shouldn't be doing this procedure if they put in 2 A-lines in 10 years, right?
Yeah. I think anybody that's on more compressor or a ventilator should have an A-line going to the ICU to start.
Absolutely.
Yeah, but also femoral
Yeah,
A-line is so simple.
I would agree.
We're
Many of
ultrasound
these-
guided. That's
but
what they-
many of these are radial A-lines, right?
Yeah, and that's, I agree. I can. Yeah, if they have a strong femoral pulse, I'm going to put it. I can do a blind or anatomically guided A-line.
But cardiac arrest patients seem low-hanging fruit because there's some literature to suggest we should be doing this, and keeping diastolics at 40-ish, depends upon whose paper you believe, during cardiac arrest. I'm putting A-lines in every cardiac arrest.
Yeah.
That's really not every cardiac arrest, but people potentially salvageable cardiac arrest, I should say.
Yeah.
You put a microstick in anybody's groin, or even if it's in the vein or the artery, you transduce it. One, you have large axis, venous axis, or two, you have a potential sheet that you can upsize, or even with the microstick, we have, can be upsized or used as transducer.
Right.
I agree.
And it'll help you it'll eventually help you with that patient's blood pressure's 50 who's entrapped, who are going to put Reboa in with a positive fast.
And if they, even, like I said, if it goes in, if it goes in the vein, you gotta go to venous access.
Right.
In the artery, you gotta.
I mean, my goal is if we could do 2 to 5 people a year for Reboa in the pre-hospital setting and save their lives, it'll be great. But we're dealing with an incredibly sick patient population, so we may not have good outcomes.
Yeah.
We need to create a microscope.
And this was, I mean, they in the paper they mentioned these are the Reboa is being used in patients with imminent cardiac arrest. I mean, these people
Right.
are going to die, so why not deploy a device that could potentially be
Can't bring them
life-saving?
to the hospital because they're entrapped, they're going to die, they're circling the drain, they're hypotensive, they're positive fast. It makes sense to do it.
And especially for us in the pre-hospital setting, having ultrasound, I mean, we can do our fast on scene if we needed
can do
ultrasound.
TEs.
We can do TEs. We can do
Right.
ultrasound guided access.
There's
And we can do
certainly
it
risk as well intimal flap. This just
So-
happened at a hospital in New Jersey. They had intimal flap, they inflated the balloon, and the patient crashed.
So there was one thing that I wanted to add about Reboa, in terms of, let me see if I can find it. In terms of the sheath that is placed for the Reboa catheter, there are some that are not compatible. That they're not compatible with the device. So
So they have their own sheath
correct
setup, right?
But they also have some other companies
There's
that you
name for
can
it.
get.
It's like Reboa introducer sheath. There's some name they have, but you can buy it separately. It's not that expensive.
The thing is, with the sheath, it
So-
doesn't matter what sheath you get, you put a wire.
No,
Right.
so, yeah, exactly. You can wire it
Right.
exactly.
Yeah.
So,
Anything else, as long as
for
you
ex-
put something in there.
yeah, and like from the Reboa website, from the Reboa company, it specifically says known compatible 7 French introducer sheets, Aero, Super Aero Flex. But if you look at Aero as a company, this is just reading off the website, not anything I particularly care about, but the percutaneous sheath introducer kit, which is what almost all of us have when you think Cordis, that's what you get. It's actually just a percutaneous introducer sheath, 7 French, 9 French, whatever you get.
I think there's
it's
a
actually
7
not
French, if I
compatible.
remember right.
What's that?
I think there's a 7 French.
It is
Yes, so that's, yeah, theirs is a 7.
Okay, so we got to try last
So you can do a
year.
5 French in the wrist if you're going to do the radial, or 7 French if you're going to go in the groin. Theirs is set up for a 7 French introducer sheath. But the thing is, there's so many different types. I mean, just looking at Aero, for example, because that's one that's on both the known compatible and known non-compatible. The Aero brand manufacturer, their Super Aero Flex, is known, it's compatible, good job, but yet their percutaneous sheath introducer kit, which is what most of us have in our facilities, is known to not be compatible with Reboa. So it's just interesting that you can have 2 things from the same company unless you actually know exactly which device or which introducer sheath you have.
And I think theirs is only $150 if I remember right. It's not.
I don't know that. I don't know the exact pricing. I was just looking at their website, kind of browsing. But I mean, there are the majority of them are compatible, but there are a few. I mean, Cook, Cook. We use Cook brand for a lot of different things. Aero, there's another very common brand that we see. St. Jude Medical, Cath Lock, and Guidewire with the 7 French introducer sheet. That's not compatible. So it's just something at least to keep in mind. I mean, especially in the pre-hospital setting, make sure at least we have the equipment that's compatible with the device.
Yeah, I think we need to move to the microstick because the Aero Femoral kit is mainly in our ER and what's in the trucks is a 20 gauge, 10 centimeter catheter. You have to do anything, not even pull all. And your wires, I think.
I mean, where I trained in our trauma centers, we had 9 French introducer sheets. Those that are Cordis, if you will, which we learned quickly. It's not a Cordis. You're not putting in a Cordis. A Cordis is a brand. You're putting in an introducer sheath. So, but that's what we had, and then where I did my residency program as our course site, we did quad lumen 8.5 French central lines. That was our central venous access. We had an 8.5 French central line. So just every place is a little bit different. So knowing what you have in your equipment is
Yeah.
But
important.
that kit we got from Community that I gave you last week, I think is a nice.
Yeah, it's nice too. All right, we're going to stop because we have a lot of stuff going on. Thanks for coming. We will be back next week on a regular schedule, back to the little bit longer journal clubs. And please email us if you have any questions or just want to come rotate with us. Have a great week. Thanks.